I think the biggest thing that's wrong with today's healthcare system as it relates to privacy and security is that you've got 21st century technology and 20th century security in a nutshell. We just haven't invested in security to the extent that we need to really get it right yet. We have hospitals at healthcare institutions that still don't have a full-time information security person. We have 30% of our hospitals that still aren't encrypting something as simple as email. We just don't have the level of investment in security that you would expect to see in companies that have multi-million dollars worth of technology and thousands of individuals' information.
And is that a perspective that you think is really echoed throughout the front lines of the healthcare industry, or is that something that is potentially undervalued at this point?
I think it's undervalued at this point. I think if you talk to the information security professionals that are in healthcare who understand what it is they should be doing and what they would like to be doing, that they would echo that they would say that those are the challenges that they have day in and day out. I think if you asked the average hospital CEO or manager or physician or whatever, I don't think that they would agree with that. They would think that they absolutely are investing in security. But I think it's a matter of perspective. I think it's a matter of understanding what it really takes to get the job done correctly. And when you look at, there's been studies done countless times. There's been a study done just not too long ago by healthinformationsecurity.com. There's another one by HIMSS every year that HIMSS puts out there that looks at security across the industry. And they all come back saying the same thing. That we're underinvesting in security. Security in healthcare is 1 to 3% of the IT budget. When you look at any other regulated industry, it's 6% plus of the IT budget. So either they're spending way too much on security, which I don't think anybody would tell you they are, or we're clearly not spending enough. And I don't know that I can necessarily fault that right now. I mean, because when you look at the average healthcare entity right now, they're dealing with ICD-10, they're dealing with ACOs, they're dealing with HIE, our Health Information Exchange. They're dealing with implementing a certified version of their electronic health record or their electronic medical record and having to go through meaningful use. I mean, there isn't enough time in the day or enough hands on deck to get it all done. And then you add on top of that the security requirements that they have that they're clearly behind on, and it just gets worse. So you look at I know our customers, they'll have anywhere from 150 to 200 active projects in IT. So when you start talking about, well, let's implement encryption, or let's implement DLP, or let's implement whatever, it's got to go in that pecking order of other projects that they've already got ongoing, and they've got to figure out who's going to do it and where the resources are going to come from to get it done. It's not an easy task right now to manage a hospital and to meet all the requirements that are out there. Unfortunately, security suffers from a phenomena that it doesn't happen until it has to. And you'd like to think that everybody does it because it's the right thing to do, but the truth of it is that we don't. We don't even do that in our own lives. We take risks in our own lives, right? Organizations take risks as well. And until there's a clear mandate to do something, typically it doesn't get done. So when you look at security in healthcare today, and you look at the current HIPAA security rule and even the high-tech rules, there is enough what I call vagary in those standards that there is no clear-cut requirement that somebody has to meet. And so what that translates to is a lot of inactivity. I think probably the number one regulatory issue that we have, or legislative issue that we have, is the adoption of a real security standard that's based on an industry-based, industry standard that's well known, that actually brings healthcare up to the same level that we have in other industries like finance, et cetera, that have a credible security standard that they base their programs on. I think what they're finding, many of them, is that it's probably more challenging than they expected, and for different reasons. And I think what I've heard is that when they've gotten into it, and they've actually had to start, this measurement process of how many of this actually happened and how many of that actually happened, and actually apply those metrics to what they're doing. A lot of them are actually going outside and getting other firms to come in and help them do that because it's a little bit more demanding than they expected. For a hospital that already had a lot of the components of an EHR implemented in CPOE, et cetera, for them I think it's a lot easier. You take a hospital that now has to go out and implement CPOE because they haven't done it yet, and that's part of the meaningful use criteria. I mean, it's not trivial. So it's actually taken them a little bit, it's actually taken more effort, I think, than some of them might have imagined that it was going to take. On top of that, I think the industry there's been the move from whatever version of software that they're on to a certified version has not been as painless as a lot of them would like for that to have been either, right? I mean, you've heard of a lot of implementations that are waiting. They're waiting for the vendor to get to them, because basically you got every hospital in America essentially that has to go to a certified version. Where are all the folks coming from that are going to actually do those transitions, do those implementations? So I think one thing that's turned out to be a little bit more complicated than folks thought it was going to be. The security piece of it, we're finding, in a lot of instances, is an afterthought. And even though it's part of the criteria, it's not something that people are actually putting into the plan, because what they're doing is they've got somebody on the clinical side or the project management side that's running the meaningful use project, and they're thinking about it from a standpoint of, we got to have this many of these kind of transactions happen and this many of these kind of things happen, and they forget that they've got to conduct this risk assessment and make sure that the 8 functionality in that EHR that around security are actually implemented properly. That needs to be incorporated into those plans as well. But I think for the most part, we've seen a lot of people who were planning on doing it this summer or this fall that are now slipped into next year, and I think it's because of a lot of things, but I think it's mainly because of just this resource issue with ICD-10 that's bearing down on them, and now you've got the ACO aspect that's out there. A lot of them, like I said, are involved in either regional or local HIEs, and all of those things are just taking an enormous amount of resources.